Good afternoon. My name is Majid Azati. I teach at the School of Public Health here. I also direct the Wellcome Trust Center for Global Health Research. It is my pleasure to welcome you to what usually would be a third Thursday of the month seminar, but it is Wednesday. And as a shifted today, which today is actually focusing on road traffic injuries. Actually, as somebody who probably has spent the past 18 years or so working on global health statistics, and I know it well. Every time I look at the league tables, I'm amazed that one of the top 10 leading causes of death in the world are road traffic crashes and injuries. It's actually, it just never ceases to actually get your attention. I use it for teaching. So something
why are you amazed?
Well, because you think of heart disease and a stroke. I know it by heart, but I use it for teaching to remind the students that top 10 include road traffic crashes, and actually top 20 include suicides, which so that's the other one. And highly geographically skewed in terms of where that burden is. It is as relevant as it gets for global health. I'm going to introduce the person who will chair the session. Actually, Richard Smith doesn't need introduction, but I'll do it anyhow. I think I know as far back as the former editor of the BMJ, there must have been a long, illustrious history before that also. So Richard turned BMJ into a really interesting and exciting journal, and since then has had a number of important roles and adventures in global health and bringing together people in ways that knowledge is generated. So Richard, over to you, and you will, direct the session and introduce the speakers.
Yeah, well, thank you very much. So, as I'm sure you're aware, if you go and spend time in a low-income country, you are much more likely to die in a road traffic accident than you are of malaria or HIV or anything else. Sadly, I've known 2 young doctors over the years die in road traffic crashes, not accidents. There are no accidents. It's not an accident, as I'm sure Don will emphasise. And I was in Dhaka on Monday, and this was the front page of the newspaper. Why cannot we stop traffic accidents in Dhaka? And there's a horrible, 9 people died that day in 6 districts. And as you'll learn and probably know already, it's one of the commonest causes of death, and it's skewed towards low and middle income countries. So we've got 3 speakers, and I think it's going to be a good session. I think there aren't very many of us. If you want to interrupt at any time, I think that will be fine, like I just did. So our first speaker is Mark Wilson, who is he's described as a professor of practice. Yeah, well, that's an interesting thing to do. What is it you practice? I mean, you could do anything. Could you? The clarinet, the saxophone, surgery.
The neurosurgery.
Right, and he's gonna kick us off.
Yeah, don't dare interrupt. Whatever you want. I've got 15 minutes, so I might be a couple of minutes over if that's okay, because I think it's a really important topic. It's not really going to be on what I think is probably the most important aspect of road traffic collisions, which is prevention more than anything else. I'm going to talk about the next sort of phase really, is what we can do into using data, crowdsourcing to minimise the impact of it. And so I should introduce my program. So I'm a neurosurgeon, consultant here, set up the neurotrauma unit about 8 years ago when this place became a major trauma centre. I also work for HEMS, an air ambulance doctor, so I've got lots of sort of trauma pre-hospital kind of roles. And this project that I'm going to talk to you about is now really quite big. It's global. It's having a big influence, particularly on cardiac arrest. But it's now starting to move into trauma, which is actually where it came from originally. I should say I've got a massive conflict of interest, which is GoodTimes is not for profit, and I don't get paid for it, but I'm the medical director of it and co-founder of it. So there's a really rubbish conflict of interest, and I'm working on a better one. Go on.
Do you mind if I tweet the lecture?
Yeah, you can tweet it. Yeah. There's one.
Yeah. I should have said that. I think that's one of the things I was supposed to say.
Yeah. No.
I think we've even got a hashtag, have we?
Yeah.
What is it? Did you hear that? IGHI forum. Sorry about that. It's completely failed.
No. Yeah, absolutely. The only thing, well, I'm going to do a little demonstration of stuff in a bit, which has got live instance happening now. So don't tweet those pictures if that's okay. I'll tell you not to do that. So I'll tell you where this whole project came from, and it came from road traffic accidents. So we would go to patients on the air ambulance, you'd arrive there and they wouldn't be breathing. And there's this phenomenon we don't really get taught in medical school called impact brain apnea, where when people or animals get hit on the head, they stop breathing. And it's been known about for a long while, but it's not really commonly understood, this is an experiment from 1896. This is a dog who was breathing away quite happily here, and then Kramer comes along with he put a metal plate on the side of the dog's head and shoots the metal plate, and dog stops breathing. And then he gets dog bag valve mask out and ventilates dog, and dog starts breathing again. Now if he doesn't ventilate dog in this bit, dog dies. And you might like to notice, for those of you interested in trauma, that during this period they get a capillary surgery and their blood pressure goes up as well, and they get a cardiovascular collapse after that. But this phenomenon of apnea, not breathing, after a head injury, is really very common. It happens in all animals. The harder you hit them, the longer they stop breathing for. And it's a well-known phenomenon in the animal world. But is this happening in humans? And well, often when we get there, they're not breathing. They've got big pupils, and they're dead. It may well have been that they've had a hypoxic brain injury prior to us getting there. So we talk about primary and secondary brain injury. Primary brain injury is when your head hits the windscreen. Secondary brain injury is everything that happens after that. So probably the first type of secondary brain injury is this hypoxia. Now we do see it like this. So people come in here. This is someone from about 3 or 4 months ago whose motorbike, come off his motorbike, and he's got this loss of grey-white and big swollen brain. So that's a hypoxic brain injury. And he died because he's got hypoxic brain injury. And his cause of death was, a traumatic brain injury. He's not died of traumatic brain injury. There's not much blood in here. He's died of a hypoxic brain injury secondary to trauma. And I'm really emphasising this because we really need to decide what we're actually calling brain injury early on to be able to know how to minimise it. And this is a guy called John Hines, who was a good friend of mine who got killed on a motorbike a couple of years ago. But he used to do the TT races and things like that, following them round. People would often come off their bike, would take their helmet off, they'd be grey, ashen, big pupils. He'd ventilate them for a little while, bag valve mask them. 2 minutes later, they'd start breathing again. And if you didn't do it, then obviously they'd end up with a very severe hypoxic brain injury or die. And often when you CT these people afterwards, they don't have that bad a brain injury. And that led us to think, well, how can we minimise this phenomenon? Do you need more ambulances to get there within 1 minute or 2 minutes? That's never going to happen. So we wanted to crowdsource care. And this is where the GoodSound Project came from. And since then, it's really expanded now. And basically, we worked out that you're never more than a few 100 metres from a doctor, nurse, paramedic, policeman, someone who can hold an airway open. And basically, we tried to get anyone who's able to provide such skills on the system. So this is the sort of motto. The GoodSound Project is to save lives using technology. We do that by using a web platform and an app. So this has roles in road traffic accidents we'll talk about at the end, but it's really got very big in cardiac arrest. And that's where, and this is live in London now, so I'll explain how that works. So if you have a cardiac arrest in the hospital here, your chance of survival is about 50%, but then most of the people in hospital here are pretty sick, so that's not surprising that only half survive. If you have a cardiac arrest on the streets outside on Parade Street, your survival is about 9%. But then people on the streets of London should be pretty healthy, so it should be much higher than that. If you have a cardiac arrest in Heathrow Airport, the chance of survival is 80%. And that's because there's an AED at every other gate, and all aircrew are trained in CPR and use of the AED. So this figure should be the same on here, because they're fit and healthy people walking around the streets as well, but they're not because of the lack of AEDs and the lack of people who are trained or getting there quick enough. And as I say, like you're never more than 5 metres from a spider, supposedly, you're probably rarely more than a couple of 100 metres from a doctor, nurse, paramedic, someone who's trained in CPR and basic life support. And we've set this up as a glue. So there's lots of organisations right now, St John, Royal Life Saving Society, most of the first aid organisations you know are on this. There's about 40,000 people in the UK on it, CFR groups, lots of others. This is what London looks like most of the time, or presuming a little bit more. The ambulance services are on it, and it's integrated with computer-aided dispatch now in CAB systems in quite a few of the ambulance services across the UK, across Australia, and all of New Zealand's on the system as well. So if you have a cardiac arrest now outside here, dial 999, yes, they're going to dispatch an ambulance to you, but there's already someone running to you on this system. And it's saving quite a lot of lives. So these are some of the organisations we work with. It's also working with various fire services and police services now as well. I should have said it's really thanks to Nesta and the lottery funding that's got it all supported to start with, endorsed by Resuscitation Council and various others. And there's lots of clever tech within this, so you can vary the radius of the response, who you're alerting, so it can be used for lots of other things as well. So for example, in New South Wales, they use it for alerting their staff to different types of things. So you don't necessarily want a member of the public going to, say, a road traffic accident. You want to alert your staff or the police only. You can control all that and the radius of alerting it. And it's built up a really good community now. I can talk a bit more about the community at the end. But within the app, for example, there's a radio feature, so you can see who's around you from your friends, and you can just press the button and talk to them. And that can be used on scene, but it can also be used to see who's in the pub or in the coffee shop, and so it's quite useful for medical students. It's also got the largest AED register. So what we did was we built into it. So if you see an AED like the one in the reception here, you just take a picture of it and upload it within the app, and then we check that's really where it is, give all that data to the ambulance services, and they can confirm the battery pads are in date so the battery are working, pads are in date, and then you can't see it.
It's a defibrillator.
Yeah, defibrillator. Sorry, should I AEDs, defibrillator. Yeah. And then that's mapped 50,000 AEDs now. It's the biggest registry in the world. And we give all that data to the ambulance services. Yes, that's a pretty big deal. We've also got a system in it now where people can track AEDs. So if you have an AED on you, you can display as having an AED on you. So it's not only got a static AED registry, but it's got a mobile AED registry. So there are 900 police cars in London, got AEDs on them. Taxis are now carrying it, or there's a rollout now of taxis with AEDs and trained staff as well. So it's getting quite good, and then everyone has to show a picture of a drone. And we're working with various organisers. This is not in England, this is in Australia, where there's big expanses where there's no AEDs, and obviously delivering drones on a coastline is relatively safe. And we can do that very well because we know where the cardiac arrest is, and we've got a team of people, as in all the responders, who can make sure the drone is done in a well-governed way. I should have said right at the start that this is all built on principles of governance and security. They're the sort of two core elements of everything we do. There's lots more that we're doing within the space now, so CFR dispatching, building up communities in various countries. I'll talk a bit about Brazil and India at the end. For major incidents, it's quite useful as well. And then I just want to talk a bit about how you can really use tech now to make a big difference in trauma. This is my take on pre-hospital care over the last 100 years. Sorry, not pre-hospital care, this is my take on the music industry over the last 100 years. The music industry went from sort of wax cylinders to gramophone records to tapes to CDs. Some of you in the audience probably know none of these things. And similarly, the pre-hospital care industry's gone from stretchers with wheels with horses, ambulances, and then helicopters. Everyone loves helicopters. But the music industry has switched over to digital. You say, well, we can't do that. That's not going to work for ambulance services, is it? But it is. It really, really is. And so within the system now, we can open up anyone's mobile phone to open their cameras. We get their permission, but just sending them a message. I'll do this at the end. I should demonstrate it. And we can see what's going on scene. We can even measure people's pulse through the camera directly. I'll demonstrate that at the end. And you can use people's mobile phones now to triage. We do this on the air ambulances that I work on. Triage both the scene, as in like how big's the fire, how many people are involved, how big's the car accidents, how many cars are in there, and triage the patient. What's their pulse? What do they look like? Whether they look grey and ashen. So you can get quite a lot of information just from people's mobile phones. And this is an example of the dashboard, which I'll show you in a second. And as I say, you can even measure people's pulse through it and get vital signs and other things that can confirm your observation. I might do a little demonstration in a second if I've got a slide on here. I think I've got it on here of actually doing that. We're actually working with St John and other organisations now to take this into the community sector as well. So if you go into the interhospital here, you'll find that there are a lot of people in the age bracket of between 70 and 90 who fall out of their chairs or fall over from standing, who have head injuries. And actually, if you look at the trauma burden in the UK, the population is really increasing in terms of our trauma workload, the elderly, silver trauma, elderly population. Many of them have relatively minor injuries, and we're seeing a lot of people that just needed a bit more support at home as well. So using this system, we not only can you alert people who are good at cardiac arrest, but you can alert people who are good at making cups of tea. To go around to Bob next door, make a cup of tea, put Bob back in the chair and see how he is, and if he's not well, then actually trigger the system as per normal. Or if he is well, just let the system also lets their son know and whoever else they want to let know on the system as well. So it's a way of actually building more communities around it. Now, there's, as I say, I'll describe the situation as it works in the UK and Australia and New Zealand. but it is also working in other places which are resource poor or don't necessarily have an ambulance service. So in parts of Brazil, it's working with a fire service to become a surrogate ambulance service. In parts of India, it's similarly being used specifically for road traffic accidents, actually, where there are people who are first aid trained who look after a particular road. One road, that's their road, and then they get notified through the system that there's been a crash at the other end of the road, and they can go and sort of be the first aider for that. And in parts of Africa as well, the video is now being used not only for the sort of pre-hospital side of stuff, but also for follow-up of patients when they leave hospital. So GoodSound, as a not-for-profit, as I say, it's a pretty small team. This is some of our team. Ali's in charge of the coding team, yeah, it's a really good bunch. I put in one little video here at the end here, which is really just to show how it acts as a community, as a glue more than anything else. This is the Ambulance Victoria video, where they've tried to encourage other organisations. So basically, hospitals can come on board as an organisation. Lots of organisations can come on board, this is the video they put together to try and get people around them on board. So.
It was half time.
I walked around the gym for a little bit.
I was playing soccer.
My legs just gave out from under me.
I felt really dizzy.
And collapsed.
I was unresponsive.
And I had no pulse.
I had a cardiac arrest.
Luckily, a couple of my teammates knew what to do.
Someone got a defib.
The guy started CPR.
The defibrillator restarted my heart.
When someone is in cardiac arrest, every second counts. The sooner somebody receives CPR and defibrillation, the greater their chance of survival. Saving lives is always a team effort. That's why we've partnered with GoodSound. It's an app that alerts off-duty professionals like you to cardiac arrests nearby. If you're a medical professional or qualified first aider, please join us. Register as a trusted GoodSound responder today.
If those guys hadn't been there, or if they hadn't been able to get a defib, I wouldn't have survived.
Pretty hard to do. I find that really emotional, I see that. But it is actually saving lives. It saves life yesterday, it saves life most days of the week, we know about them. And that's for cardiac arrest, but it's doing a similar sort of thing in trauma, as I say. Have I got time for a very quick demonstration? Yeah. Like 5 seconds? Yep. How do I get out of this? Exit. Okay, so this is the system live right now, and you can load up people on it. So this is GoodSound people, the people with the little defibrillator sign carrying AEDs with them. So if we just look at London now, this is other organisations like HEMS and the red people at other organisations. So this is live in London now. So if someone has a cardiac arrest around, here, this guy will get alerted to it. And if you're drunk, you can't go. If you're in the shower, you don't hear it, you can't go. That's fine. This ambulance is still coming. It's just it's a emergency sort of service before that. There's lots of things I can go through here, but I won't do it. I'll just show you the thing working live.
So what's the difference between the red and the green?
Oh, so green people are registered under GoodSound. So when you register on the system, it's very highly governed. You have to load up your work ID, your GMC number and things like that, and then you come on the system as GoodSound. If you happen to work for, say, London's Ambulance Service or St John or one of those, you can select those other organisations. They appear red. So just because I'm showing you the dashboard here, the green is just the GoodSound people. London, everyone's so happy with the governance behind it that actually they're happy to alert everyone. But some organisations, when they start out, for example, East Midlands Ambulance Service, which use it, start off alerting their staff only, get comfortable with that for a few months, and then start alerting St John, the police, fire. Do you see what I mean? It's a glue between lots of organisations. So these are cardiac arrests happening live right now. Again, if this is the bit I don't want people to tweet pictures of, if that's okay, because it's real information. So that's someone there. This is live right now in London. Let's have a quick look. So unconscious, ineffective breathing down there. That chap doesn't look like he's going at the moment. Who else is there? Oh, he's not accepted it yet. So these are sort of. That's one in East Midlands, and that person's on scene now. They've just got there and just rocked it. 4 minutes. She got there 4 minutes ago. So it's real. It's happening, and she's got an AED with her. So hopefully, that might be an extra life saved. And these people are getting here within 1 or 2 minutes after the 909 call, not 8 minutes, which is kind of a bit late. That's for cardiac arrest, as I say. It's being used for other things elsewhere. If I can just show you the video side of stuff. So with the air ambulance work now, if you're going to dispatch an aircraft for half an hour and take it offline to go to someone with a burn, it's useful to see what that burn is before you go, because it might not be a tiny burn, it might be a big burn. And there's lots of other examples you can give around that. And I can ask anyone's mobile phone. I'll just use mine just for, rather than anyone showing their phone number. 947. So there's no app in this. Okay, this is the point is it's just literally sending a text. I can use someone else's phone if they want me to use theirs. So you say to the person on the other phone, okay, it'd be really helpful if I could see Bob. I'm sending you a message. When you get that message, can you just click on it? And so you just click on the message. It will ask if it's okay to share your location and to share your data. So if you say yes to those two things, I'm saying okay to data, okay to location. And with that, it should find me. So it says here I'm in St Mary's Hospital around here. And the video thing's opened up. So I can now open up the video. Now it might be a bit slow because sometimes it is here, not too bad. And it's just coming out that camera at the moment. I'll just hold it like this. So if you see, I should get a red box around me in a second. And the bottom right hand corner down here somewhere is my pulse. It's usually about 50 odd, 50, 60-ish. Can you see it? So I can actually tell everyone's. Do you mind if I point at you? If you don't mind, if you do mind, just duck. But actually, if I come over to you right there for a second, it's not recording it. So there we go. It should just take everyone's pulse.
Well, it's going up as you're doing it.
Yeah. So well, if you try to, if you get one very close.
So what is it? What is it?
Oh, your pulse.
How does it do that? There's a percentage button at the top. There's a percentage at the top.
There's a problem. You need to see it.
Maybe my skin's too dark.
No, it'll be alright. I'll get that. Oh, I know what it is. Sorry. Glasses do screw up actually. There's a percentage bar on the top. It'll keep going up. There's a percentage that they will. Hopefully will.
You're relaxed, Richard.
If you give it a second, if you give it about 30 seconds, it gets up to it. No, it's pretty accurate. We've done tests on it. It's anyway, and you can also measure respiratory rate through it as well. So that's the kind of stuff that you can do now, which I think gives an opportunity to provide care remotely. That's not only not only can you provide care in terms of diagnosis and triaging, but actually you can also provide care by saying that person looks sick, open their airway, and start to give instructions, run that burn to under the water, all those kind of things. So you can provide care before we even get there. So I think the world of technology and provision of medical care is really going to change rapidly over the next 10 years or so with all this kind of stuff. Yeah, that's pretty much it.
So maybe just a couple of quick questions for sort of clarification before we move on.
So, road traffic crashes that would be fatal, how many of them need
So that's a really good question.
Because I mean, in some sense, what is it that can be? So I mean, I heard about the India case with taxi drivers.
Yeah, they use this. Yeah.
Sort of Uber model for this purpose. So I guess I mean, how much of this involves managing it on the scene, getting the person to a facility faster, and any of it yourself? But I just don't know what the sort of shares are.
So it's a really good question. So, and in the air ambulance world here, the majority of what I do is not actually interventions. The majority of it is decision making. You're sick, you need to go to that hospital. And most of the paramedics are pretty well trained. So with them, I can say, oh, I think this person needs this doing or that doing, and they can do it. So you don't physically need to be there. Obviously, there's stuff that doctors do, like intubation, thoracotomies, that are, and giving blood and things like that are more medical. But actually, majority of the important things are decision making, which can be done remotely. And I think that's where the big difference, this is where this kind of stuff makes a difference, because, yeah, it's easy to do that.
Thomas, I'm a paediatrician.
Hi. Well, so data is interesting in terms of numbers because we very much rely on the ambulance services to tell us about when they've survived. So if you look at, I'll give you one statistic that's fairly big. So East Midlands Ambulance Service introduced it for 10 months until about a month. They're still running, but their first 10 months where they only alerted their own staff. So they weren't alerting the public. That got 30. There were 30 people who got ROSC. Return of spontaneous circulation from them arriving as a GoodSound responder before the ambulance arrived. So that's 30 people in 10 months, and that's just in East Midlands. And we know of a survivor probably at least every other day that comes through the system. Let me give you an example of our very first survivor, because it was great, when we found out the first survivor. Most of them we find out through Twitter or through Facebook, and this was one we found out through Facebook. And this was a guy who is 52, he was down in Bromley. He'd been to Taekwondo. He's actually a medical person. He'd been to Taekwondo and sat down. And this was in a church, not a church, a village hall. Sat down on a little bench and then just collapsed. Someone dialed 999, and walking up to the church just outside were two St John people carrying an AED to go and teach CPR and AED in the church. So literally, their phone went off, and they burst through the doors within 90 seconds. Slapped the AED on, shocked him. Went to King's, got stented, and he's fine. Back at work about two months later. And that was pretty impressive, that was good. And then there was some awards ceremony where the two St John people got an award from London Ambulance Service, and the guy had written a letter to them saying, "Thank you very much for saving my life." Fair enough. What you probably aren't aware is that my wife died 5 years ago, and I've got two sons, 1 5 and 1 3. What would have happened to them? And then it really hits home that it's not just sort of obviously that person, it's just everything else that goes with it. So, yeah.
So against that, can I ask you, how many people have you got being defibrillated who've just had a bit of a faint because of fanatics?
So we don't know that number, but they shouldn't be being defibrillated because AEDs shouldn't defibrillate you if you're just being a bit funny. AEDs are pretty safe. We've had people where I know a loved one has tried to start CPR and then someone else has turned up and gone, no, stop, they're having a seizure, and things like that. So there's a few of those. We've not had any, touch wood, bad things happen at all yet. And I'd say it's pretty highly governed. There's a good code of conduct with the ambulance service and things like that. Yeah.
Good. Well, Mark will be here for the discussion afterwards.
Yeah.
So now we're moving on to Don Riddlemeyer, who's come all the way from Canada. So we've given him longer to speak. He's going to talk about optical illusions and traffic crashes, findings from big data science. So Don is a senior scientist in the Evaluative Clinical Sciences, Trauma, Emergency and Critical Care Research Program, Sunnybrook Research Institute. And I was once speaking in his institute, and he came up to me afterwards and said, "I'm going to give you feedback on both your talk and your personality, because I expect you don't get much of it. So I'm going to do the same thing."
I feel the heat. Thanks very much for being here. Thanks as well for dealing with the slides. Great stuff about advances in pre-hospital care by capitalizing on the social network. Good comments as well from our pediatrician about, our measures of effectiveness being so important. When you crack open one of those AED packages at my hospital, it costs you about 400 Canadian dollars, i.e. about 200 British pounds. Anyways, that's not what I'm here to talk about. I'm going to speak for about 30 minutes using about 24 slides focusing on traffic injury as an opportunity for improvements in global health. All right, the content is my current favorite project, divided up into background, theory, findings, interpretation. I'm going to stick pretty close to my notes so that I don't run over time. And I apologize in advance for my thick Canadian accent, my awkward Canadian style, and any other faux pas of interpersonal repartee. Don't get distracted by the suboptimal mannerisms. The points here are important, even if you're not interested in traffic safety. There are methodological developments on the horizon when it comes to big data. Disclosures are on this slide. Nothing really untoward except my own ego bias. And ego bias is every bit as powerful and sinister as any financial conflict of interest. These parties, though, are relatively neutral when it comes to roadway safety. All right, what's not controversial? This is the only non-controversial slide in the talk, so you can leave early if you've got other competing demands. First is that traffic crashes really are a major cause of mortality. About 1.2 million deaths per year on a global basis, far exceeding now malaria for the first time in history. Not bad for a cause of death that was unheard of a century ago. Not as serious as strokes, but about on par as global deaths from lung cancer, for perspective. It's a major cause of morbidity as well. For every person who dies, about 20 are left permanently disabled, either with their spinal cord injuries or their post-concussion syndromes or their chronic pain situations. About 20 million people each year, to say nothing of the 50 million additional people who suffer large financial costs when they ding their vehicle or worse. It's a high load on emergency medical services. A 70-year-old guy with a myocardial infarction at my hospital is a big deal. A 17-year-old guy with a motor vehicle crash is way more disruptive to the flow. The yelling, the screaming, the splattering of blood, the broken bones, all right? We all suffer from lost time. Most of us don't really think we're going to be in a motor vehicle crash this month. Au contraire, we are all flooded by the cascade of traffic congestion. We all personally feel the results of these collisions, even though we may not be directly involved. We all pay the costs every day, and it's not through vehicle insurance. Most of the damage that's done by roadway crashes, the drain on the economy, is from the property loss, right? The cost of consumer goods and services, right? If the Coca-Cola truck driver is involved in a motor vehicle crash, then the price of Coca-Cola must go up, or at least fail to go down. All right, so that the bulk of the expenses and the costs add up to about 2% of the gross domestic product of most countries. All right, so for the United States, that's about $1 trillion per year. Even if you reduce crashes by 0.1%, you still save billions of dollars to the economy. There is a substantial lifetime risk. You know, the average adult's lifetime risk of a serious road crash in the United States is about the same as the lifetime risk of a serious heart attack. And think of all that we do for risk factor prevention, diabetes, the hypertension, the hyperlipidemia, and how little we do in terms of primary prevention when it comes to road crashes. And indeed, most crashes can be prevented, i.e., if I have a patient with pneumonia or multiple myeloma or Crohn's disease, it's not exactly clear where their life went off the rails. Not exactly obvious what I could have done, what could have been done to prevent that. Whereas when it comes to road crashes, almost all of them can be entirely avoided by a small change in driver behavior. So that let us not be fatalistic about this. Things could be a lot better this afternoon. Now, how do you make things better? Here are the 5 ways to reduce road traffic crashes, all illustrated with photographs and alliterated by the letter E. All right, enforcement. Enforcement is just a great way to stop people from speeding, running stop signs, and driving drunk. The main downside with enforcement is that it's just not a public relations winner. If you want to get reelected as a politician, you cannot lobby on being tough on this form of crime. Economic incentives are a great way of getting people to act prudently. My favorite is a high price of gasoline. The main downside is knowing how to price all sorts of other violations, like a speeding ticket or a parking ticket for that matter. Engineering advances are also gorgeous and hugely effective for the vehicle or the roadway. The main downside about that lever is our near total lack of significant engineering advances in the roadway or the vehicle in the last 40 years. And absolutely in the question and answer session, I will field any question you want to throw about me about self-driving vehicles. Education. Education, I think, is a huge adjunct to any policy changes. The main downside there is that the effects of education are just so modest when tested in randomized controlled trials, with the only exception there about being a few education interventions in the military. Effective medical care, I think it can be life-saving in the aftermath of a crash. The main downside is that it's just so costly, and many of the people who survive do not survive intact. And about 1/3 of those who die at the scene within 10 seconds of impact, really not leading much opportunity. So all these approaches are helpful but not sufficient, so more needs to be done for traffic safety on a global basis. Which gets me to my next slide to introduce today's research project. And in particular, here are a few puzzles that have been on my mind for many, many years. First is that most life-threatening crashes occur in daylight, and most are more frequent in July than in January, particularly in Canada and a bunch of other Scandinavian countries. Moreover, most are not due to drunk drivers, and many occur in young, healthy individuals who otherwise would have lived long and fruitful lives, like James Dean being an example of that. Almost all crashes reflect driver errors, and yet almost all driver errors do not cause a crash. The average drunk driver has to travel more than 1 million kilometers before they hit anything. And so those months and months of uneventful travel inevitably breed a false sense of security and an element of self-deception that somehow I can hold my liquor. Finally, if I close my eyes, I cannot sense my speed. That is, the modern engineering and comfort of regular vehicles means that I can't tell the difference between going 30 kilometers per hour versus going 60 kilometers per hour unless I look at the speedometer. I can sure tell on my bicycle, but not when I'm driving in a car, all right? Now, a lot does happen when I do open my eyes because I live in a very cluttered, three-dimensional world where I need to use cues when judging distance. And these cues are okay for close personal space, like this pen, not bad for near action space, like that bottle of water, not so good for distant vista space. How far away is that mountain, is that hill? All right, so here are two images that show a subject in the front and mountains in the background. The first is a painting of the Mona Lisa where she appears closer to us than the surrounding mountains. And similarly here with this colleague who is crisp and clear and therefore appears close, whereas the surrounding landscape is dim and dusky and therefore appears distance. That's the optical illusions that our eyes do automatically in order to produce a three-dimensional image out of these two-dimensional renderings. And the name of that optical illusion is called the Rayleigh effect. And it's actually a pretty good rule of thumb, right, because of the scattering of light waves because of intervening airspace, all right? The problem is that it breaks down under situations that are either very bright or very hazy. Under those circumstances, that same optical illusion, which is so useful 90% of the time, can cause problems. And because traffic is so fast moving and so closely packed that even a small error in judgment can lead to irreparable consequences. Okay, so that's background theory. Now, of course, people don't fully realize the fallibility of their own distance judgment. So here's a way of demonstrating the optical illusion in this lecture theater this afternoon. Specifically, consider this image that contains 5 balls of different positions, sizes, and colors. Now, the red ball is closest to the edge. Ask yourself, which ball is closest to the red ball? Is it the yellow ball, orange ball, green ball, blue ball? Let's have a show of hands. Which ball is closest to the other red ball? Who says yellow? I would say yellow too. Orange, orange. Some people say orange. Green, green. Nobody going for green. Blue. Anybody going for blue? Oh, we do have some blue ones. All right. All right. Now, you see, the problem is that if you draw the concentric circles, lo and behold, the green ball, not the yellow ball, is the closest of the four balls. All right. In this case, you see, most people judge the yellow ball as relatively close to the red ball and judge that dim green ball as relatively distant. However, the exact measurements show that it's about a 20% difference. Thus, our eyes can be deceived and misjudge distances even in extremely simple situations. That's the illusion of the aerial perspective bias. Now, this same optical illusion shows up in and can be extended into more realistic traffic situations. Here's an uncongested roadway right by my hospital in Canada. It's Bayview Avenue for the one person in the room who can recognize it. And each image shows 3 cars in the lanes where we drive on the right-hand side in Canada. The leading car is black, the middle car is orange, the trailing car is red because, you know, but the traffic flows in this direction when you're in Canada. Now decide whether yourself, whether that middle car is a little bit closer to the black car or a little bit closer to the red car. Now, if you just show respondents this image where it's crisp and clear, the orange car appears closest to the red car. Whereas if instead you dock up the image with a lot of extra aerial perspective bias and make it fuzzy and faint, then it appears farther away, therefore closer to the black car. All right, so that's the issue of misjudging spaces. And of course, the actual photographs are identical, but most respondents, again, make the mistake. That is, clear objects appear close and faded objects appear far, and bright sunlight, therefore, can change our judgments. So now we get to the question at the 14-minute mark. All right, and so, and specifically, does the risk of a life-threatening traffic crash increase under bright sunlight? Now, bear in mind, there are a whole bunch of operating words here, all right? We're using life-threatening to denote any crash that sends the individual to the emergency department, although not necessarily to the operating room or the grave, all right, so that they send you to the hospital. A traffic crash means involvement as either a driver or a passenger or a pedestrian, because we all share the roads, all right? We don't use the word accident because either that's too fatalistic or too trivializing, as Richard already said. If a small child spills their milk, that's an accident. When somebody else wraps their vehicle around a tree, that's something much more serious. And then we use this term bright sunlight, which means daytime, not nighttime, obviously, and it means that 50% or more of the dome of the sky is free of clouds. That's the technical definition of bright sunlight, all right? Not to be confused with partially cloudy or fully cloudy, which will show up pretty soon. And I realize that this is one of my most counterintuitive study questions ever, since most people think that it's the exact opposite case. Specifically, it's that dark, rainy, windy weather that's so dangerous for driving, and that nice conditions are going to be nice for driving. However, what's going on here is that under clear, bright light, all the distant terrain seems crisp and clear and close. Therefore, drivers misjudge their progress down the road, all right? And it seems to take too long to make it to that hill, which just seems to be just hovering there in the foreground, all right? These sort of faraway objects seem unduly close, and we misinterpret that as our own speed is rather sluggish, and so that tempts us to speed up faster. And that optical illusion isn't just idiosyncratic to Wedelmeyer. It's going on in every driver on the roadway. So if I check my progress at the nearby traffic, we're all getting sucked into this optical illusion. All right? So that the excess speed might ripple through the entire fleet of vehicles. Okay, so now we get to some research details to back this up, all right? So to do so, we look at Canada's largest trauma center over 20 years, identifying all patients hospitalized for traffic crashes, and we focus on daytime hours, which I'm going to approximate as from 7 p.m. to 7 p.m. And then, so that if there's a crash, and then what we do is we find control days 1 week earlier and 1 week later. I.e., suppose there's a serious crash right outside of Paddington Station Wednesday afternoon at 3:45, okay? We look up at the sky and we ask, is it bright and sunny, all right? We then go back to Paddington Station exactly 7 days later, Wednesday afternoon, 3:45, and then we again check what the weather conditions are like. Is it usually bright and sunny outside of Paddington Station? And then of course, we'll do it in a time machine and go back 1 week before the crash as well. Same place, same time, same mechanism, look up at the sky and find out what the weather is, all right? And through the magic of big data, of course, we don't have to send out medical students with their shoe leather in order to go to Paddington Station. We get it all from these sort of automatic weather networks, all right? And we don't actually have them transcribed. It all gets sucked in with Python programming and so forth, all right? So that's sort of the overall. And then what we're going to do is we're going to test whether bright sunlight is overrepresented at the time and place of a crash, okay? And then we can also calculate strengths of association. So here we go into some details of baseline characteristics on the sample size of 10,000 individuals. No informed consent here. It's all universal care. In Canada, the so-called Big Brother is watching you. Here it is. So 10,000 total patients, and they are right here about whether they are included in our study, about 7,000 patients included in our study as daytime crashes, and the remaining 4,000 are going to be excluded. Those crashes occurred in nighttime, all right? And then we've got some selected attributes on this case-only design. These people we are excluding for a long time, although they will come back later on. All right. Notice the wide spread of ages. Again, because we all share the roads together. You know, younger people, older people. Notice the preponderance of men. All right. With a ratio of 2 to 1. It's despite their greater body weight and increased bone size, bone strength. It's not that they're so fragile. It's that they're so foolish. I can say that. I'm a man. All right. Notice that there are many miscellaneous events here, all right? Hundreds of them, all right? Whenever you have a very large database, you're going to see very, very kooky things arise. I notice that the majority are not related to drunk drivers, only about 11%. Of course, drunk driving is less common during the day than at night. And some individuals have very, very heavy injury severity scores. I mean, above 35, that's substantial. But these are not trivial cases that are being admitted to the hospital. Okay. Now, here we get to some of the most difficult results. And I'll start it off easy. All right. And they are the main results of the 7,000 included patients from the daytime crashes. Arrayed here on what seems to be 3 simple circles, showing the raw counts according to the prevailing weather at the time and the place of the crash. All right, and so overall we see that of the 7,000, about 2,500 of them have bright sunlight prevailing at the crash. Whereas if we go back 1 week later, only 2,200 of them have bright sunlight. Or if we go 1 week earlier, only about 2,200. Again, so Paddington's station here. So that there's an overrepresentation of bright sunlight that coincides with the occurrence of a crash. Got it? So that number 25 is just consistently bigger than the number 2,200. All right? And so from that, it means that there's roughly a 10% increase in the chance of bright sunlight associated with a life-threatening crash. Got that? And then through the magic of statistics, that flips to a 10% increase in the chance of a crash associated with bright sunlight. All these fans of case control designs, it's the same sort of magic there. All right? And so then we get this sort of relative risk increase of about 10%. That's the easy part. All right? Because remember, the data were assembled as matched triplets, because it's big data science, all right? So think of that like, you know, those old-fashioned lectures about McNamar's test, right? And when you had on-diagonal elements and off-diagonal elements, and it's really the discrepancies that test the hypothesis, because the weather sometimes clusters together. Sometimes every single day at Paddington Station there may be bright sunlight. All right? Bright sunlight on the crash day, bright sunlight on the control days. Those sorts of triplets tell us something about the prevalence of bright sunlight. They tell us nothing about the relative risks associated with bright sunlight. So it's the discrepancies, either the one-way discrepancies or the two-way discrepancies, that matter. Not an easy thing to wrap your mind around. All right, so here's the way to portray it, the triplets according these objects called Venn diagrams, which you probably haven't seen since high school. And oddly enough, there are some medical journals today that refuse to publish Venn diagrams. And yet you can't do this form of big data science without it. I'm not using any Greek symbols here or any equations. These are all very simple counts here, all right? Now, what do we have? So here are the 2,500 days now arrayed according to whether bright sunlight was the only day in the triplet on the crash, and that both of these days were cloudy, not bright and sunny. Whereas these days, all three of them, both the crash day and the two control days, 300 of them had bright sunlight prevailing. In a few cases, there are overlaps. What do we see here? That the number 1,000 is generally bigger than the number 900, that the number 500 is generally bigger than the number 400. What a beautiful sense of transparency before I get into any of the real heavy-duty equations. What a great way to see whether I'm making any programming errors. All right, and that leads us to this conditional odds ratio, not of 1.10, but of 1.16, the right way to do it. And a 16% increase in risk is a big deal, far greater than the safety gains that you get from an airbag installed in a motor vehicle. You can then take that estimate of 1.16 and subject it to boundless secondary analysis, because the databases are so big. And like here it is arrayed. There's the point estimate, but but that's the 95% confidence interval. Anything that excludes 1.0 is statistically significant and at the nominal 0.05 level. All right, so what do we see here? We see that, that the increased risk with bright sunlight is a little bit bigger on weekdays rather than weekends, suggesting what is going on here is regular commuting and not recreational travel. We see that the risk extends both to the summertime and the wintertime, all right, even though, of course, bright sunny days are just much more common in the summer. That the increased risks extends throughout all of the demographic subgroups, suggesting what's going on is not just a function of brash young men who are prone to overconfidence. Instead, the results suggest that the increased risk is a part of normal psychology and not idiosyncratic psychopathology. Why end there? You can do some more a subgroup analysis in order to explore more nuances, a huge strength of big data science, again array. All right, so that what we find is that the increased risk is still found in those who do buckle up, suggesting that many of these people were actually health conscious and safety minded. Most crashes do not involve alcohol, and the increased risk has nothing to do with those with detectable blood alcohol levels. The increased risk extends regardless of how far away from the crash site the trauma center was, suggesting that it's not a fluke of some sort of referral bias or the pre-hospital care system, and that the risk extends to the highest level of crash severity. Maybe there's an increased accentuation. Together, these tests of robustness suggest that the increased risk justifies some countermeasures. All right, the weather is not the only component of bright sunlight is not the only component of the weather. So here are results now in graphical format. There's our 16% increase associated with bright sunlight, much greater than what is found in partially cloudy weather or fully cloudy weather, about on par, maybe even slightly greater than what's observed with rainy weather and snowy weather. Here are the negative controls for those people who want a tracer analysis. High barometric pressure does not significantly increase or decrease your risk of a crash. Low barometric pressure doesn't significantly increase or decrease your risk of a crash. Again, we're double checking to find the absence of an association where you would expect an absence of association. My last result slide is right here, and that's where we're now going to bring back for all the crashes that occur in the middle of the night and array them according to 24-hour clock time. Midnight is right there at 0 hours and 24 hours. Noon is right in the middle of the day at 12 hours. And it shows that the increased risk disappears after the sun goes down. So it's not a function of bright starlight, only a function of bright sunlight. And it's not explained by the hours near dusk and dawn. So it's not got to do with glare from low lighting. And again, it shows us an advantage of big data for doing all these exploratory nuances. For the 5 minutes left, here's the summary slide. First, that bright sunlight leads to an increased risk of a life-threatening crash, contrary to intuitive beliefs prevailing in the community. Second, that the 16% increase in risk is substantial, extends broadly, and is far greater than the benefits of airbags for protection. Thirdly, that the absolute increase might explain about 1 in 20 serious daytime crashes, because bright sunlight is relatively frequent and modestly risky. So it doesn't explain the majority of what's going on, does explain a very small sliver of a very big pie. All right. Now, speculations about possible explanations. Here are the 7 classic traditional explanations for traffic crashes. One possibility is increased amounts of driving distances on sunny days, but that doesn't explain why the increased risk is more apparent on work days rather than weekends. A second possibility is increased alcohol consumption, but that doesn't explain why the risks extend to even those with no alcohol detected. A third possibility is always motorist fatigue, but that doesn't explain why the risk occurs in the middle of the day and not at night. A fourth possibility is overconfident moods, but that doesn't explain why it also applies to older women who are hardly prone to recklessness. A fifth possibility is decreased a police action. But that doesn't explain it, because enforcement is actually particularly easy under bright sunlight. A sixth possibility is reduced medical care, but that's unlikely because emergency medical care is universally free and available in Canada. And a seventh possibility is increased distractions while driving, but that's unlikely because sunny weather usually is no big surprise. Hence, most of the factors that are usually blamed for traffic crashes are unlikely to explain this particular finding. So in my next slide, I speculate about different explanations that are consistent with the data. Namely, that fallible distance vision means that normal motorists have a hard time gauging their speed. In particular, clear conditions make all distant terrain seem unduly close, and therefore bright sunlight makes the approach speed of surrounding landscape seem slow and creates a faulty impression of not making good progress down the road. And in turn, normal drivers might then compensate by accelerating faster in bright sunlight. That is, the speeding that contributes to life-threatening crashes may be rooted in faulty speed perception and not deliberate recklessness. And the comfort of modern vehicles means that drivers can't tell the difference between 60 kilometers per hour and 60 miles per hour, even though the risk of dying has just gone up by 100%. All right, our fallible perception is at the root of it because we didn't evolve to travel at 20 meters per second. All right, so on an awareness of this finding, therefore, might encourage some more interventions to prevent life-threatening crashes under seemingly harmless circumstances. The simplest intervention is education for increased awareness, such as perhaps a tag to weather reports, such as the slogan, "Don't ruin this beautiful day with an ugly crash." They could certainly put that on the radio with the weather reports. Enforcement might also be effective if not carried to extreme, such as photo radar that can check every vehicle regardless of racial profiling. Economic incentives, they can be more difficult unless carefully crafted. I like the idea of in-vehicle data recorders attached to automobile insurance discounts. Engineering advances could be simple since many people appreciate helpful reminders. I would love a little chime in my smartphone that went off whenever I was traveling more than 120 kilometers per hour. I don't want to be fined for doing that. I would like a gentle reminder. And yet sometimes inadvertently I start going that fast. And early warnings by physicians can also have a role for doctors who want to save lives, such as counseling active adults about unsafe driving in the same way they do about unsafe sex. All these solutions are rooted in the insight that life-threatening crashes are caused by excess speed, and that excess speed may be inadvertent because of an optical illusion. And so on my final slide, here's where I'm going to end the talk. And the specific point that bright sunlight was associated with an increased risk of a life-threatening traffic crash. And the idea that optical illusions while driving predispose normal motorists to a mistake that can cost them their lives. Here now is a way that you can predict a crash with sufficient time to avoid it entirely. Consider this for your own personal safety, for traffic policy, and a recommendation to patients, as well as think as well about these self-matching designs for all sorts of other forms of big data to improve global health. Thank you.
Thank you. Just a few questions before we have the last talk, and then we'll have a panel session. Joshua?
So aside from the fact that the UK should have much less accidents, I have 15 days of sunshine. Sorry, I had to do
Okay.
We were all thinking it.
Yeah.
Is there value in looking at countries where they have variable speed limits for weather conditions? So for instance, you go through France, you go through Spain, they have signs specifically that gauge your speed to say, you know, if it's sunny condition, this, if it's rainy condition, that, those types of data sources or results in that context.
I agree totally. Like, it can play into variable speed limits you might want to adjust, but you don't want to adjust with insane amounts of exuberance. And you want to have a counter argument to all these motorists who detest getting tickets and say, why did they ticket me? Things were perfectly fine. All right. Au contraire, that's the deception to try to fight against.
But I think you have to tell us, does it mean there are more accidents in Spain than there are in Britain?
Well, I've not studied Spain, all right, but like those data would be available. Britain does very well in terms of traffic safety, only about 1,800 deaths per year, way more on a per capita basis than the United States. That a little sliver
Way
maybe
more.
the weather. No, way less, all right. A little sliver maybe the climate. A massive chunk has got to be the gorgeous public transit system here. What a life-saving device, all right? Whereas it's not just your car, it's your freedom, that mentality in North America.
But I mean,
Insane.
presumably you would expect to see more crashes in Texas than in Maine or something.
Yeah, although those ecological biases are so problematic because of enforcement and roadway structure, that's the advantage of these self-matching designs, whereas they perfectly control for driver training and roadway vehicles and so forth. Yeah.
So, it's very, very interesting. Were these crashes cars running into each other?
Okay, so that we don't actually have that degree of granularity because I'm a physician. I don't really read the paramedic reports, all right? But I mean, about half of them are with a stationary object, a tree, and about half of them are colliding with another moving object.
Is it not just because there are more cars on the roads during the day?
No, we've looked at that pretty carefully, and in particular with the commuting as well. There's other studies that if you take a look at superhighways outside of Toronto, and that, you know, as the sun goes up, the mean speeds certainly accelerate, not just the flow rates. Okay.
Right, one more question then, well, two more, and then we'll move on and listen to Seema.
So, I would imagine in this day and age, not for controlling individual drivers, but for getting averages. That should be available to actually test the specific hypothesis. But then the other thing is that presumably in downtown Toronto, and I am from Toronto, so I and around Sunnybrook, you know, that's not where the speed is going to go up a lot. So you know, you would see this effect a lot more on, you know, the road between Toronto and Kingston or wherever than you would in the city, because you know, doesn't matter what the weather is, part of, you know, or one you would, but not that. So all of these should actually, I mean, and it should be testable using simulation. So you should be able to put people in simulation rooms and say, look, if you change the lighting, I mean, so I think the phenomenon that summer crashes are more than winter is known, and the fact that sunny is, but I think that whether it's the light, and you know, Canada introduced the daylight driving as one way, so it should be actually from an intervention perspective very testable of why this happens.
Yeah. Very testable with high levels of granularity, right? If you just compare, you know, the British Isles to Spain, there are going to be so many differences in culture, it'd be very, very hard to disentangle that. But with the inbuilt loop detectors, you can certainly see increases in not just with the mean velocity of cars under bright sunlight, and there's the same chunk of roadway, but also the upper tail of like with the percentage, but that are going, say, more than 10 kilometers above the speed limit.
We're going to have the panel up.
Yeah.
Oh dear, now I'm suddenly conscious that we've had all these men.
Yeah,
okay, yeah.
He answered 2 questions.
Okay, yeah.
You know, evidently there's good data that if the first question is asked by a woman, then women ask more questions. So when I chair, I try to remember that. So why don't we, let's have both your questions.
Okay.
I'll have to make to the panel.
Okay, good.
All right, great.
So
Thank you. So I'm not sure how confidently you can discount the hypothesis that it's not the older women effect, because you know the same factors that influence the risk perception in men would also from a higher risk perception, from a higher baseline. So then I was wondering whether you could separate those two factors in the laboratory, so maybe in a driving simulator.
Yes.
That you might want to consider that. I can't think of.
Yeah, you know, the sort of the idea of overconfidence being a contributor to a motor vehicle crash is so compelling, it's almost a non-falsifiable hypothesis, right? In the aftermath of a crash, you can always say in hindsight, well, they were just too confident for the circumstances, all right? There's almost an element of circularity to that theory. You're right, the way to disentangle it directly would be with a simulator study warning people to be cautious. And you know, the only thing that I've shown here indirectly is with the demographics, and not completely compelling.
Good, okay, so sit down, Don, and
Okay.
I'll get to you in the panel. So actually, I've seen it remarkably, we're on time. Exactly. So this is Seema Yalamanchil, who combines, she's both a surgeon and a big data person. And she's going to talk about novel data in road traffic injury and trauma systems.
Thank you, Richard. So I'm a general surgery registrar. I work at St Mary's, but in my spare time I'm doing a PhD. It's actually the other way around, but it feels like I'm doing a lot of clinical work at the moment. So I'm really grateful to being asked to come and speak, because the topic of what I'm talking about is the background to my PhD, which I feel really passionate about. And road traffic injury, as kind of people have alluded to before, is something that's a little bit neglected in terms of, you know, the global community's resource allocation and just in terms of spotlight. But I think there's a lot that can be said about it. It's really interesting, and there's a lot can be done to address the lives that are being lost through this issue. So just really to go through things I'm going to touch on, but very quickly, because I think my job here today is really to provide an idea about some of the concepts around this topic rather than going into my PhD in detail. And hopefully it's something you can take forth and sort of advocate for those who are suffering with road traffic injury. So talk a little bit about the global burden, and then a bit about surveillance data, which is kind of the crux of how I think we might go forward with this, and specifically crowdsourced surveillance data and the opportunities that it presents. Richard combination of Richard and Don and Mark have sort of said a little bit about road traffic injury, but I think it's quite important to give you some context, and Majid as well mentioned he talks about it at the beginning of his courses and things, but it's huge and it's growing. We are 18 months away from the end of the decade of road traffic injury. It was a UN and WHO decade of safety plan for road traffic injury, and the plan was that by the end of 2020 we would halve road traffic injuries, and we haven't. They're going up actually, and they're going up in the countries that have the worst infrastructure, so low and middle income countries. And to give you just pictorials, ignore the text inside, but that's trauma altogether. That big red man at the top is global trauma. That is HIV, the grey one is HIV, TB and malaria clubbed together. So that's global burden of trauma, and that's the rest of those together. And people just don't see that difference in scale. This is just distribution, so this is high income countries, this is low, middle, upper middle. But you can see this is where to look at the whole of injury and trauma, 25% consistently across the board is road traffic injury. So if you take that on a global scale, we've got 5 million dying from trauma. It's 1.25 that road traffic injury. And just to update on Don's fact about malaria, we've just overtaken HIV. So the last global burden of disease survey, HIV was 1.1 million deaths per year. We are now 1.25 with road traffic injury alone. We've overtaken it, and the spotlight is still not moving towards us. So it's just a really important sort of policy and advocacy message to be getting out there, which is why I'm labouring it a little bit. And in low and middle income countries, there's this huge economic burden that comes alongside it, because it is young people, it is males, these are often the breadwinners. So in terms of impact on a household, that's huge. And in a lot of these contexts, their health systems work in a way where it's out of pocket costs. So that household loses its breadwinner. The cost of healthcare is going to have a secondary sort of impact. And if you're not going to die, you might have significant morbidity going forward, which again is going to have an impact in these settings where they don't have access to good rehab and return to societal sort of contribution. So this is the problem. This is kind of where we're starting off in trying to address. And sort of mid-2010 to about 2013, the WHO, part of this sort of movement to try and get things going with trauma, said we need to have trauma systems in developing countries because low middle income countries need to take what we've learned in high income settings and apply it, which is, it's a very broad brushstroke, and there's a lot of reasons why that's not suddenly going to happen. But just to give you a bit of background about what a trauma system is, it's very much a health system, but the crux of it is ever so slightly different, and the emphasis moves a little bit more in sort of pre-hospital direction, is because it's time sensitive, a bit like stroke, a bit like cardiac. It's about time to definitive care. That's what's going to get you greater survival. So just very simply, so you conceptually got an idea, because the crux of what I'm trying to get at is how we get trauma systems better in these places without changing their current resource allocation. You've got injury, so at point of injury, you've got to get from there to the right place. That's your pre-hospital services, be it now, people, whatever else, triage to the right place. In the UK or high income setting, we've got different levels of care, so very injured, tertiary centre, you know, trauma units or sort of small hospitals if you're sort of alright, and then you might not even go to one of those, so just maybe minor injuries or GP if you're not a major trauma. And I won't go into definitions for that too much, it's not so important for this. But you've got like a feedback loop, so if you collect data of the people going through the system right the way across, you can start to see what the patterns are, and you can start to resource allocate, and you can start to say where do we need more information, where do we need to put people, how can we optimise the system. And that's kind of where I was coming from with this. And I've mentioned, you know, the two main killers really in injury, regardless if it's road traffic or not, are brain injury, which Mark's spoken about, and major hemorrhage, both of which are time sensitive. So that's one way you can reduce your time to getting to a definitive care. The other way is to stop them happening in the first place. And those are kind of, for my work, that's kind of what I'm trying to go for. Big ask, I know, but I think that's where the money is. So, like I said, you've got this whole system, you're trying to collect important information about what's going through that system, and really it's this thing about surveillance data, and I don't mean security, I don't mean defence. Surveillance in this context is public health surveillance. This is data about a disease. We collect it for TB, HIV, malaria, but we're not so great with injury, and there's a couple of reasons for that. A lot of it is because it is so time sensitive, and the other reason really is to do with, in low middle income country settings, up to, not always, but up to 80% of those deaths are happening pre-hospital. So if you don't get, if you get to a hospital, you might turn up on a trauma registry. They might take down your details and note your injuries as being part of something that happened through a traumatic injury. But if you don't get there, you might not be logged as a trauma. And so a lot of the difficulty around global injury statistics are to do with this patchy data. Patchy, we're doing a lot of sort of estimation work, which makes it difficult. But you've got this big pre-hospital problem where you don't know quite what's happening, and you can't build that picture very easily. And if you're going to make a trauma system, if I just go back, well, it doesn't really matter which slide I'm on, but if you're going to make a trauma system, one of the things that, I mean, London was a little bit different because we're very urban, quite dense in terms of population, and kind of for various reasons picked the different parts of London that are going to serve as major trauma centres, and the others as sort of trauma units around it. But when Scotland was designing theirs, they had to do it in a different way because their population density and distribution is very different. They're quite rural. They've got islands that are out in the not off the coast. They can use their ambulances at different times because of weather, blah, blah, blah. So what they did is they looked at where injury was happening, what times of day it was happening, where their centres were, well, current centres were, and then they basically tried to optimise that in terms of geography and mathematical calculations and modelling. And that's kind of what I thought would be useful for countries which haven't got the resources or funding or possibly even political will to invest in trauma. You do have a set of existing hospitals and potentially some pre-hospital services. How do you best configure them? That was a nice idea, except for the problem was they don't have this data. They don't have the numbers that I could plug into a model to say, well, this is how you best configure your services. So what do you do then? You're not suddenly going to be able to get people to start pulling the data, because the reality is traditional public health methods of surveillance are quite resource intense, take human resources, they take time. There's a bit of a lag often between when you get that data and when you can, you know, get it into a form that you can use. So is there a way we can circumvent this? And this is kind of like one of the key concepts that I want to get across. It's crowdsourced surveys. And Mark talked a little bit about crowdsourced, and actually I should really sort of go back a step. I'm interested in any novel source of data, anything that's an open data source, anything I can get my hands off by being the public, or anything that's not coming through traditional public health methods, essentially. But let's talk about crowdsourcing for a little bit. And here's a couple of examples, just so you get a bit of an idea. So crowdsourcing is sort of come to the fore really in the last sort of 5 to 10 years because of crisis management. So for various reasons, if you have a situation where you haven't got many resources but you've got an acute crisis, it drives innovation, it drives disruption of traditional ways of doing things. And Haiti was one of the classics that we saw. Let's see if I can get this to work. So this is an OpenStreetMap sort of video showing, I don't know if it'll show up very well with the lights, but all that signal was basically crowdsourced mappers, people interested in mapping the new systems, the new setup in Haiti. So the red lines are roads, and there's secondary roads which are green, and each of those blue things, that's all new refugee camps. And can you see that the white flashes are every time somebody put up they looked at what was coming out of satellite information, aerial photographs, and updated the maps. So those maps were built by people nowhere near Haiti, looking at data that was remotely accessible and updating in real time to give a map that people on the ground could use without having to do the traditional thing, which is sending out people to remap the whole thing. And you can imagine in an acute crisis, it takes forever. It's not particularly accurate because it takes such a long time. So, building on from that, we've now started to move. Has anyone heard of Google Flu Trends? Yes, a couple of people, right. So Google Flu Trends, Google thought it might be an idea, and it was an idea, it was a good idea, it just didn't quite work out initially, to look at the searches that people were putting in and to see if they could find a way of working out who possibly had flu and where that flu was, and could they start sort of picking up disease trends using their search engine and the way people were using the search engine. For various reasons, that didn't quite work out, but the concept wasn't an erroneous sort of idea that could have been mine. So we have now gone on to develop a separate arm of public health surveillance, which is computation epidemiology, where we look at various sources like social media, and we can use natural language processing to look at text and start to identify whether it creates enough signal for us to say, actually, there's an outbreak of X, Y, and Z. It's happened and worked with Ebola, with Zika, and influenza. The question I'm going to ask is, can we do that with road traffic injury? It hasn't been done yet, but I think road traffic injury lends itself really well. It's not a communicable disease, so it's not about migration patterns and people moving back and forth. This is about a different set of behaviours, a different set of patterns that I think are relatively predictable and things that we can start to look at that can be pulled in through crowdsourced data in a similar fashion. So that's kind of the basis of my PhD. We've started taking social media feeds and other crowdsourced information or data sets. So navigation apps, things like Waze, they are used by various people in the public, and they upload, you get prompted and you can upload your, if you spot a road traffic incident, and that's another source, and we are benchmarking against the data we have in London, because as people have alluded to, London's got a really amazing set of data in terms of the health, the traffic, and the transport sector, all of it, from police as well, is a really good set of control data to check against. Because ultimately, I think this is where it would be useful. The uptake of mobile phone use and cell phone data is vast, and it's crescendoing right across South Asia, South America, and in particular Africa as well, to the point where these are just 2 articles. That one's actually from the end of last year, but this I don't know if anyone follows Medical Futurists, but this came out this week. This is a way I think we can circumvent the time it takes for traditional infrastructure funding and political models to sort of come up the development curve, and we can get to the people who need this stuff the most and start to help them to build the trauma systems that they're going to need a lot quicker than they would do by traditional means. So that's the crux of what I'm trying to do. That's my plan and hypothesis, but at the end we hope we can do all these things. Thank you.